everyone. You're listening to another episode of the Colleague Down the Hall podcast. I'm your host, Janine Wolf, and I'm joined today by Linda Tai, who is a trauma therapist who specializes in cutting-edge brain and body-based modalities for healing of complex developmental trauma. I recently completed a training with Linda called Befriending the Nervous System, which is an insightful experiential training with strategies for trauma, sensory processing, and developmental wounds. And I am so thrilled to have her as my guest because I just learned so much in that training. And today we're going to talk about understanding neurodivergence in trauma work. Welcome, Linda.
Thank you, Janine. It's so wonderful to be here with you all today.
Yes, thank you. Okay, so there has been more and more recognition of the ways that trauma and neurodivergence can overlap in presentation, but with differing underlying causes. And that's what I found so helpful in your training. So can you just tell us a little bit about your work around that, or just jump in wherever you want with this topic?
Sure. So, in terms of my own professional journey, I got hyper trained in a whole bunch of trauma reprocessing modalities because I was all about trauma, 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 trauma. And then at one point, my clinical supervisor says to me, Linda, there's more to mental health than trauma. And I had that whiplash moment where,
Really?
yeah, like, really? Yeah, and then I started working with cases where I really saw how med management was incredibly helpful. And then I started really noticing, by this point in my career, I was really noticing that with my clients with whom I was working on their complex developmental trauma, that for some of them, it didn't look like they were getting better. It looked like they were getting worse, right, in air quotes. And I held a curiosity and an openness around that. And then at the same time, I was also getting referrals where people were self-referring. They'd done a whole bunch of trauma therapy, years ago, and they wanted to come and see me because they saw that I was trained in a bunch more modalities. I live in a small town is the context. And I'm working with these folks using the trauma techniques that I was trained in and not seeing much progress in air quotes. And so that's when I started to do my own deep dive into ADHD and autism specifically, because what I was doing wasn't working. Yeah. And around the same time, I also had a couple of clients where I was also doing that. I was trying to do the trauma work and it wasn't quite landing, or we weren't making headway. And I was thinking, okay, there's either a whole bunch more symptomatology that I'm not aware of, or there's more going on here. And because their issues were confounded by person and environment issues in terms of family members, I was bringing their partners in. And then once I brought their partners in, I was like, oh, okay, I see what's going on here. My client is neurodivergent or the partner is neurodivergent. And so there's that mismatch thing happening. And so that was how my journey evolved. And then somewhere along the way, it also became part of my own journey in realizing that there were things that were popping up in me and I had nowhere to place them in terms of trauma symptoms. And then I did my own work around racialized trauma. Yeah.
Okay.
And then there was stuff that was left over, and I could really see that the elements of neurodivergence emerging there. So it's been a fascinating journey.
Yeah, and I'm so appreciative of this journey because you recognize that there was this missing piece and you sought it out. And there's so much more acceptance isn't the right word, openness to learning more about neurodivergence these days, at least within our field. I don't know about the world in general, but I feel so many more professionals are learning more about it, not like what it used to be framed in the past and the symptoms that were noticed in the past, but that this is a little more prevalent than we thought and impacts people in different ways. It impacts women versus men in different ways. And then to go on and see that, so you have these overlapping symptoms. So you might have a person with trauma who is also ADHD or autistic. And so knowing the underlying cause impacts the way you treat them. Is that correct?
Yes. One thing I write in my notes is how assessment and diagnosis is ongoing and continuous. Yeah, because some things
Yes.
we don't know about until we become aware of them. And so these days, when I take a history, like there's what the history says, and yet we know that there's so much confluence with trauma and sensory processing and neurodivergence, and also retained primitive reflexes, which is an area that I'm getting into now, that it can be challenging to pass that all apart. And so this is where I find the neurodiversity affirmative paradigm, which very much is rooted in like feminist paradigm, which also has parallels, in terms of affirming someone's identities that can then be so incredibly empowering for someone as they move forward. Yeah. And it's that piece about self-empowerment within a context where we recognize that there is a lack of community support for so many of us, of many identities. Yeah.
Absolutely. And I love the self-empowering piece. One of the things that I realized, I was late diagnosed ADHD, and I heard this expression and I could never remember the second half of it because I wasn't ready to remember it yet. But now I teach this to my clients because I work with a lot of neurodivergent women in particular. And so the expression is ADHD is not an excuse. And then my brain would just stop there. But the second part is it's an explanation. And I encourage my clients, like, learn about what this means for you so that you can deal with some of those negative self-perceptions that you developed from trying to be neurotypical because you were neurodivergent in a neurotypical world. And it's so empowering to learn about these things. And also along the way, you can't help but discover strengths as well. For most people, I think.
Yes, absolutely. And to not close the door with the neurodivergent piece, right? So to go, yes, an explanation isn't an excuse. Sorry, it's ADHD isn't an excuse, it's an explanation. However, there may also be more explanations that we have yet to uncover together.
Yes, I
So,
love that.
so to not close the door with the ADHD piece. Yeah. Yeah, because you are not a diagnosis either.
Exactly. Right. Yeah. Yeah. And I see that piece that I think sometimes we forget that assessment is continuous, and you can work with a client for a long time and still uncover these little epiphanies or insights or nuggets. And then you like really are seeing the case with a whole new perspective, which can be so helpful, which I also have to put in a plug for peer consultation, which I'm a huge believer in. There's nothing better than talking to a colleague who has a different theoretical orientation and helping you with the case because they look at it differently.
Yes, absolutely. And that's where I love my, complex developmental trauma case consult groups. And I also love the consult groups where, we come from different modalities, different specialties. I've had clinical supervisors who are trained in all the things I'm trained in. And I've also sought out clinical supervisors who have entirely different worldviews.
Yes,
And different
yes.
trainings, right? It's wonderful.
Mhm.
It's wonderful. And here's the other piece I'd also recommend as well is to also engage in case consultation outside of the silo of mental health.
Mhm.
Yes, if you can be a part of a multidisciplinary team where you're able to talk about a client, but to bring in, say, the functional and integrative medicine piece, and to bring in the occupational therapy piece, and to bring in the chiropractic piece. For me, this is all incredibly fascinating. Incredible.
Yes.
Yeah. I got good advice a long time ago from a therapist friend who said, if you really want to specialize in something, for example, ADHD, then go to your ADHD conference, but go to an occupational therapy conference that looks at ADHD.
Right. Yeah,
Yeah.
and you talked about that in the training when you were talking about sensory processing, and that occupational therapists can be huge helps for us in that realm because they're looking at it on such a deeper level than we are trained to. And they can bring insights that can be really helpful in our treatment.
Yes, yes. And because occupational therapists can be hard to access, I recommend that therapists have a basic understanding of sensory processing difficulties and challenges and disorder, because it can help to build rapport with a client. It can help them to feel seen and heard and normalized. And we can also then create a map of your senses, the ways in which you become overwhelmed or underwhelmed. How do you know? And then what can we do about it? And so to take that data to an occupational therapist means that you're going to have more traction more quickly because you've already got that as data.
Right. Yeah, I think that the more we learn in this field, the more we realize we've got more learning to do, because people are complex, they're complicated.
Yes. Yes, I started, I was a yoga instructor for 10 years before I got into the therapy game. And I was all about the somatic therapies and somatic psychotherapies. And then the more I got into the body, the more I realized that there was more into the body to go.
Right, right.
Yeah.
Yes. Yeah, I think it's I don't know. That's a different tangent. We'll leave that one alone. But yes, we always have more to learn in this field. And I also find that most therapists love to learn. They're constantly like reading the next book or talking to the next person or going to the next training. And I think that's really wonderful about our field.
Yes, because we're so open-minded
Right.
and we're willing to consider other possibilities and other ideas. And it's such a strength that so many of us have as therapists, but also within therapy culture.
Yeah. Yeah, I agree.
Mhm.
Okay.
Yeah.
Okay. So I sort of got us off track a little bit there, but I'm enjoying talking to you. So let's talk about so in the training you talked about some of the overlaps. So let's look at, ADHD and autism and some of the overlaps that we see with PTSD and how the response to those or the tools that you teach or the therapy that you provide really is different based on, because a lot of, I would say all people with ADHD and autism have some level of trauma, especially if they were late diagnosed. But even if you're diagnosed as a child, the world still expects you to function in a neurotypical way.
Yes. I big shout out to Janae Elisabeth of Trauma Geek for their work around distinguishing between autistic traits and autistic trauma, and to bring that information and pull it forward into ADHD traits versus ADHD trauma really
Hmm.
helps when I do the psychoeducation with clients so that they can distinguish between the areas that may not change, or actually we may actually see more of these
Okay.
symptoms in inverted commas. We may see more of these traits emerge as we actually address the trauma. And this doesn't mean that we're failing at our treatment plan. It means that as we take away the trauma associated with your need to mask and self-protect, that need to mask and self-protect actually diminishes. But then how can we support you as your innate neurodivergence begins to emerge so that it will flourish, so that you can flourish?
Yeah, I love that perspective. And that's not a resource I'm familiar with, so I'll be checking that out for sure. Okay, so can you speak more about either ADHD versus ADHD trauma versus PTSD? I'd love if you could get into that a little bit.
Sure. So let's just start with the sensory processing piece, right? So in the general population, between 5 and 15% of individuals experience sensory processing disorder, in the sense that it actually merits um, the sense of not being functional in the society that we currently have established. And yet the rate is also higher when we look at it in terms of sensory processing differences or sensory processing preferences. But when we look at folks with ADHD, then we're looking at 50% of ADHDers experience sensory processing disorder. Yeah.
Hmm.
And for autistic folks, that goes up to 75%. Yeah, so 75% of autistic folks experience sensory processing disorder. So when I look at neurodivergence, I actually then go, okay, let's go 100% sensory processing, fill in the blank, whether it's a difficulty disorder, challenge, preference. Yeah. And so we pull that forward, and then we have to pause and ask ourselves, is this a sensory meltdown? Am I experiencing sensory overwhelm? Have I gone into a sensory mediated dorsal vagal collapse? Or is this a trauma trigger that's causing my body to respond? Yeah, so just being able to pause and create that discernment allows us to be then more effective. We know that with PTSD, we can have secondary sensory processing avoidance as a result of PTSD related sensory stimuli. Yeah, but that's like secondary to the traumatic event, which is then a way in which we can distinguish between, is this a sensory processing thing, or is this a PTSD stimulus related, avoidance related response? Yeah. Yeah. And so in that situation, something like EMDR or brain spotting would actually be really effective, because it's got that trauma element to it. But you can't use a trauma treatment modality on your sensory processing preference or disorder. Yeah.
Right.
Yeah. And so that's where you can just trial and error. You can go, let's brain spot this, let's see what comes up. Right? And that's where it's like, oh yeah, great. We just brought that to a squeezed lemon zero. And there may still be sensory preferences underneath that that are more manageable. Yeah. However, when it comes to the sensory processing disorder, that's where I would actually refer out to the realm of an occupational therapist, where if it's a sensory preference, then, we're able to gain traction with that, as mental health therapists. Yeah. Yeah. And so that's where I typically start. And then I look at sensory burnout and sensory meltdowns, because we know that when your sensory template has more connectivity in it, then you're more likely to experience the world as overwhelming. And then you're more likely to override. And so when we look at the trauma responses of fight, flight, freeze, right, attach, cry, and submit, I think another trauma response that we often overlook is the override. Yeah, we just override, we mask, we just dissociate and keep going. And so to be able to pause and go, okay, is this a sensory burnout? As in, is it autistic burnout? Is it sensory burnout? Is it depression, or is it dorsal vagal collapse? And there can be elements of all three, because we can get really depressed about how much we override, but we don't call it override, right? We get depressed about how hard we work, but then how exhausted we are, and how other people seem to be functioning just fine, and there's something wrong with me, and that therefore I then feel depressed toward myself and my body and my situation. And then I try and override even harder. Yeah. And then I'm pushing myself even further. And so that's where, and particularly for neurodivergent therapists, it's actually important to pause and go, is this compassion fatigue? Is it vicarious trauma? Is this grief? Or is this like sensory burnout?
I think that's a great distinction to make, because we tend to presume it's all burnout. But depending on our neurotype, our nervous system, our sensory processing abilities, they can be very different things. And so we might have very different underlying needs.
Yes. Yes, absolutely. Oh, and to throw in there, it could also be moral injury and institutional betrayal and systemic exploitation. Right. So there's a lot to actually make distinctions with there.
Yeah. Yeah.
And it could be
Or it
all
could
of the
be a
above.
combination of several of those, right?
Yes. Yes. I'm just going to throw you a list of questions. These are the list of questions that I ask when I offer a peer consultation or clinical consultation around this. So, so we've got the sensory questions, and then is it ADHD daydreaming? Is it the ADHD time vortex where time disappears and dissolves? Is it ADHD understimulation? Or is it dissociation because I'm overwhelmed? Is it ADHD impulsivity, or is it a PTSD narrow window of capacity? Or is it a trauma response of avoidance and got to get away from here? Is it ADHD hyperactivity, or is it PTSD hyperarousal? Is it ADHD rejection sensitivity, or is it a CPTSD abandonment wound? And I know that I ask these questions in terms of either or, but it can also be both and.
Yes.
Yeah. And that's where that empowerment piece and the education piece is so important, because we then get to find that answer for ourselves. Yeah. Is it ADHD executive function and emotional regulation and attention issues, or is it PTSD hyper and hypoarousal? Right? And it could be both. And I don't have any sort of definitive answer to any of these for anyone out there. It's a journey of holding someone's hand and walking through it together. Is it ADHD object impermanence, or is it avoidant attachment? I only found out in the last couple of years that an ADHD trait is object impermanence. And
You
I didn't
know, you've had that example in your training. Like, if my loved one is not in front of me, they cease to exist. And I was like, oh my gosh, you're like talking to me right there. Because if I'm out of town, like, I love my husband, but I don't think about calling him per se. Or my friends will get irritated. They're like, you never text me. And it was so helpful for you to explain that, Linda. I cannot even tell you how helpful that was.
Yes, right. And then people, through the lens of attachment theory, think that there's something wrong with me, that I'm avoidant attachment. Is like, no, you're just not in front of me. You're not physically real.
Right. Yeah. And ADHD brain, I'm not sure so much about the autistic brain, but the ADHD brain is constantly jumping from one topic to another, exploring things. Like there's a lot going on up there. And if something's not right in front of you to get your attention, there's other stuff that has your focus.
Yes, yes, yes. And I can only focus on so many things at once. And that's typically like one thing before I jump to the next one thing.
Yes, right.
Yeah. Am I an extrovert or am I a sensory seeker or am I ADHD? Right? Where I like novelty, or am I actually living in avoidance and I'm chasing, fascination outside of me, which can be like a PTSD trait, and it could be both. And to me, it's just so fascinating. Yeah. It's, alexithymia, we also know is common for folks who have interoceptive challenges. And we also know that those interoceptive challenges also correlate with having a smaller insula, which is a part of the brain that helps not just with self-awareness, but also being able to register information on the inside, which then creates a feedback loop. And so alexithymia, not knowing what you're feeling, we've known that it's a PTSD trait for a long time. And it's only recently that we've recognized that it's a neurodivergent trait. And yet when it comes to PTSD, it's a secondary trauma trait, meaning in order to survive repeated traumatization, my body brain has learned to prune the synaptic connections between my somatosensory neocortex and the parts of my body that experience discomfort or distress. And emotions are physical sensations, right? So if there's overwhelm with no one there for you, then I'm going to reduce those synaptic connections and numb myself from feeling my body. And we also know from early imaging brain scans for folks, for neurodivergent folks, that those interoceptive challenges actually begin very early on. And so is my alexithymia, my inability to contact my emotions, is it trauma related? Is it a skill that's not taught? Is it a trait that's not valued by my family or cultural systems? Is it a personality trait that that has emerged due to overwhelming sensitivities? Or is it so therefore it can be like the sensitive neurodivergent template that has learned to adapt by shutting down connectivity? Or is it an innate born trait? And the answer is, I don't know, but let's start the process.
Right,
Let's
right.
start the process of befriending the body in the ways that are available, and let's see what happens next.
Yeah, and just embracing curiosity. I think sometimes we get so caught, and I blame this on the DSM. And since I accept insurance, that I have to use the DSM, but we get so caught up on, okay, if you have this diagnosis, then you have this, and this. But really, we need to tease that out a whole lot more. And maybe
Yes.
we need to use this diagnostic code because insurance needs it. But the way that we're working, we can go so much deeper than that and help clients uncover where they're
Mhm.
coming from, where these things are, how they're showing up in life, basically,
Yeah.
and what are the things that work for them and what are the things that don't. And we want to help with those.
Yes, because at the end of the day, the DSM is a list of symptoms and it
Mm.
does not give rise to nuanced conversations around cause. And so to actually make headway, we actually need to be able to get curious about what root cause is happening. But in the meantime, we work with social supports. We work with challenging and disrupting the systems around us in ways in which there is mutuality and relationality, where we can all be nourished and grow. Right? We then work with building that capacity for self-empowerment through self-education and advocacy. We work with reducing stigma, right? Because when there's stigma, there's going to be discrimination. We then work with learning how you learn, because when you learn how you learn, you can learn how to do anything. And we then work with getting the additional supports. It could be with functional and integrative medicine and nutrition. It could be referrals out to a team of support that we access over time, depending on what is helpful for us at each point in our healing journey. And it can also look like bringing in family members who may be neurotypical or may not be neurotypical. Yeah.
Yes.
And then we weave into this other aspects of identity around sexuality, gender expression, race, ethnicity, religion, all the additional aspects of biopsychosocial, spiritual, and structural.
Yeah. When I'm talking to therapist, I frequently say, like, we are humans who happen to be therapists because we put so much on ourselves. But we need to apply that to our clients too. There are so many complicated layers to any person. You
Mhm.
know, their neurotype, the environment they grew up in, the type of parent and their parenting style, and, transgenerational trauma, and like just so many different aspects. It can feel a little overwhelming, which is why I love the list of questions that you have, because it can feel, all right, so I'm going to focus on these two when I'm working with my client next week, because I feel like we need to sort of tease that out a little bit more and see if we can understand what's at play with this particular thing that we've identified that we're trying to help them with.
Mhm. Yes, 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 absolutely. And that's where being able to discern between, say, concrete thinking and rigid thinking is really helpful for us as clinicians, because concrete thinking is a neurodivergent trait, yeah, whereas rigid thinking is a PTSD trait. Yeah. And the autistic brain builds learning from the brainstem up. So in working with autistic clients, I actually don't, I use metaphors that are helpful for them, but I let them generate it. And we actually speak very concretely, and I let them ask their concrete questions so that we can actually build and scaffold in the education and then the skills. And I find with
And
my
I,
clients,
I'm sorry.
there's a lot more of that, the building of psychoed through concrete learning. And I
Yeah.
need
And
to distinguish between those two for me to go, oh, I get this now.
right, looking at all those layers and recognizing the complexity there. I was also just going to say that if people aren't familiar with scaffolding, it is so important to understand that, because that is a way you can address so many things with clients, that you're not going to just throw this thing at somebody and they're going to be like, okay, I got it. But we've got these layers that we're going to build upon, and skills that we are building upon, and, the types of therapy that we're providing for that particular person, and just recognizing that we've got all these layers. And so you're not going to get it right in the first session, probably. It's going to take time, and it's a learning curve, and we're constantly assessing. So there's so much there.
Yes. Yes. Whereas for many of my my ADHD clients, I start to scaffold in, and then they'll go off onto tangents because their brain learns in a different way, right? They want to bring it in experientially, and then they want to talk about it, and then they want to apply it to other people's circumstances. And then I've got to rein them in to like their own circumstances. And then we need to unpack it situationally, right? In different contexts. Yeah. And so it feels like I'm a chimpanzee riding on the back of a swan. Like, where are we going here? Who's in charge?
Right.
Give me the
Yes.
reins.
Yes. Oh my gosh, I love that. Absolutely.
Yeah. And it can be a lot of fun. Like, it can be so
Mhm.
much fun. Yeah. And I find that the process is so much more important, because the process actually allows me more insight into how their brain works, how this specific individual in front of me, how that their brain works. Because the reality is, if you've met one autistic person, then you've met one autistic person.
Yes. Right. Yeah. So we, like, literally, if you like kicked my family tree, that all the ADHD brains would come pouring out. But we're all different. And when I had my own journey of, being diagnosed later in life, and then trying to help my family see this, and they were all like, what are you talking about? No, no. And I'm like, well, it doesn't, like, this is what ADHD looks like for Janine, but ADHD might look like something for someone else. And my whole point was, the more we can learn about ourselves and how we function in the world, the better we can make it for the next generation. If we all learn and embrace this, then, they're going to be one step ahead, or probably five steps ahead, where we were.
Absolutely. And then this is where we need to have those conversations about supports and the sensory template. I know that for myself, if I've spent, a half day in the outdoors, or even an hour in the outdoors, then my ADHD brain isn't so extremely ADHD, right? And so
Mhm.
that's where I recognize that so many of my ADHD just symptoms are actually distress symptoms. And those distress symptoms are beacons that are screaming at me to say, go and be in nature, go stare into the distance, look at the horizon, move your body, get your vestibular system active, use the big muscle groups of your body to lift and push and pull and carry. And after that, your ADHD traits will then become your gifts into the world. And that discernment between my ADHD distress symptoms or your autistic distress symptoms and your innate traits is something that then emerges over time as we begin to get to know ourselves better. And fundamentally, at the heart of therapy is people come back because we help them to make more sense to themselves.
Yes. Yes.
Yeah. And so what is it for you, Janine, that fills your bucket that then allows your ADHD traits to flourish and be a gift into the world?
Creativity, being an entrepreneur has been so good for me to I've started a couple businesses. I get to be creative and doing those things. I love the outdoors as well. One of the biggest things for me is laughing. So when I laugh, like we go to the movies and my husband's like, you always laugh louder than anyone. I'm like, because I love laughing and it's like, if it's opening the door for me to laugh, I'm going to have the best laugh I can have. If I want to go with my friends, I want to have a great time laughing because that is so helpful for me.
Do you love going to shows where you can just like scream at the top of your lungs?
Yes, absolutely. And I live in a resort city. So we have a lot of free live outdoor music here. And so we go all the time and we can sing along as loud as we want to the band or scream and clap. And yeah, it's just for me, those extremes are really important because I do find that one of the things you've talked about is I find that I am a sensory seeking person. So I'm looking for that adrenaline rush, but I'm not aware when I'm about to tip over into now I'm so overwhelmed. I feel like my skin is crawling and I've got to go find a dark place to like get myself together.
And I noticed as you were talking about screaming and making loud sounds, like your body is like moving,
Yes.
right? And there's something about being given a space where we can unmask, right? Where we can just flail with our arms and legs and scream and be spontaneously unmasked. That
Yes.
is so
Yes.
important.
Yeah, and embracing that it's okay to do that and really worry less about what other people think. In the training, you talked about the first time you tasted Swiss chocolate. And just like that, you were showing your mouth and your eyes and your body, you were showing that reaction and embracing that this is a really multi-sensory experience. And if it's the thing that really lights us up or, helps us, then embrace it, embrace it.
Yes, yes. And if it's okay, your body's doing like when you said embrace, you were going into like this,
I know.
like, but not like your body went into a fetal position, but not a distressed fetal position. It's like I'm
Hmm.
being swaddled fetal position.
Right.
So if
Yeah.
it brings you comfort, right, you
Hmm.
can actually put yourself in a swaddle shape right now.
Right.
And
Yeah.
yeah, and do the things that give you permission to like feel this primary sense of nourishment and comfort.
Right. Right. And then we also can take that a step further and remember that those visual cues with our clients are so helpful because oftentimes people are reacting with their body in some way when they're talking about something. And so keep an eye on those things, observe them, notice them. And be curious. Like I noticed when you said that you did this. Have you noticed that before? Have other people like commented on that? Is that something if it's supportive, then embrace that. Understand that that's good for you. Do more of it.
Yes, 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 for sure. And to have an office environment or to create an office environment where it's okay for folks to unmask and experience the pleasure of like their bodies being able to move and rock and express.
Yes.
Yeah. And Oh, sorry, go ahead.
No, I was going to say as a child, I was always being told I was too loud. And there's so much shame attached to that. And now I just refuse to be quiet. Like I can be appropriate in the right settings. I get that. But when there's a chance where I can be, you know, the bigger sense of myself, using the things that really help me and support me, I'm going to do that. And if other people don't like it, I don't know. When you hit your 40s and your 50s, I'm 58. I worry so much less about what other people think. So I'm like, yeah, you can just go somewhere else if you don't like what I'm doing, but I'm loving myself right now.
And your unbridled joy is also my unbridled joy.
Right, exactly. Yeah.
Yes.
I love it's just like why people like so we have all these outdoor music, live music, and people love it when kids come walking along and they break into a dance. And so it's like if you can enjoy that in children, why wouldn't you want to see that that's great for adults too? We don't always have to conform to these, societal standards.
I agree 150,000%. I say, yeah, yeah to that.
Yes. Oh my gosh, this has been such a delightful conversation. I'm feeling like we might have to do this again sometime because there's just so much to learn and you really are very perceptive and curious and you are very cutting edge on a lot of these things because, if we don't embrace the overlap in PTSD and neurodivergence and all these different things and get curious, we really are doing our clients a disservice. And so I so appreciate the work that you're doing because we need that in our field. And like I said, I feel like more therapists are becoming open to understanding neurodivergence, but we always need to keep learning because I was newly trained in brain spotting at the beginning of the year. And I just so love that, they would keep saying, like, we're still learning about the brain every single day. We don't know exactly how all this works, but we know it does work. And maybe 2 years from now, we'll have information we don't have now because humans are complicated.
Yes, and there's evidence-based practice, but there's also practice-based evidence. And the
Yes.
individual in front of you is the practice-based evidence.
hmm And that's interesting you bring this up because I was reading a discussion among some, I was in a therapist space and there was a conversation going on about evidence-based practice. So I actually looked it up. And it was very interesting to me to see that a number of years ago, the APA actually came out and said evidence-based practice is actually looking for what the client needs and using whatever therapy or treatment they need. That's evidence-based practice. We tend to think of evidence-based practice as it has to have like a certain number of studies with a certain number of, participants. Then, you've got the placebo effect and, what they're actually getting. And so I was really interested to read that because I think a lot of us look at that in a different way than what even the experts in our field, those leading our field, are saying that it is.
I agree. And as someone who provides continuing education credits in many of my courses, I know that to get to offer CEs, I need to offer at least three published articles
Mm-hmm.
that have been published in the last 5 years about
Right.
whatever it is that I'm teaching about for each hour of continuing education in order for the APA to sign off on that.
Yeah.
Yeah, so I agree with you.
Yes.
And there's this other arm of the APA around
Yeah, I
CE.
was going to say yes. So there's just a contradiction there.
Yeah, yes,
And
yes,
that's probably why some of us are confused because we're told one thing, but then actually, we do need to stay up on the latest research and the current learning and those things. But we do also have to recognize that it's our job to be the expert on our client and to
yeah,
figure out what they need from us.
yes, yes. And that's the value of peer consultation.
Mhm.
Yeah. Yeah, for
Absolutely.
sure.
Oh, Linda, thank you so much for joining me today. This has been a lot of fun and very informational. I hope that the listeners have really learned. I'm sure that the listeners have gotten some really awesome nuggets from you today. I do want to ask you if you have a favorite phrase or an analogy or metaphor you like to use in therapy.
I don't have many, but the one that I use with all of my clients is hashtags. So I use hashtags to explain trauma and trauma-related stimuli. So, for example, you go to a movie theater, right? And for you, the movies become hashtagged in with popcorn and friends and fun and blowing off steam on a Friday night, right? So those become hashtagged in together the way in which we have social media hashtags. But say something bad happens at the movie theater, then all of a sudden the hashtag movie theater now becomes hashtagged in with that unpleasant experience.
Mhm.
So if it's gun violence, then it's hashtag movie theater. It becomes hashtagged in with gun violence, hashtag popcorn, hashtag I
Mhm.
can't breathe, hashtag where are my friends, hashtag Friday night, yeah, hashtag I want my mother. Yeah. And so
Mhm.
then we get all of these things hashtagged in with each other. And then you might be at someone's home and someone brings out some popcorn, and then all of a sudden, popcorn, the hashtag of popcorn ignites the hashtag of what happened at the movie theater. And that hashtag is the one metaphor that I use. I'm not very good at
Yeah.
metaphors, but it's, yeah.
Well, when I heard you talk about that in the training, I just love that because it's such a way, like everyone knows what hashtags are unless they've been living under a rock. And there probably are some seniors out there who maybe don't know what that is, or people who really don't like social media or technology. But most people, that's so relatable. Like they can understand. We can try and describe the connection of all those things. But when you put it together as a hashtag and all the things that fall under that hashtag, it makes so much sense. And so I love that. Thank you so much for sharing that. Okay, so we need to start wrapping up. Linda, can you tell the listeners where they can find out more about how to connect with you or where they can learn about more about your work or your trainings?
Sure. If you head over to www.linda-thai.com, that's linda-thai.com. There's a website, there's lots of fun stuff on there, lots of musings, lots of the newsletter archive, current events, things that I've got coming up in terms of courses and classes. And there's also a monthly newsletter if you'd like to sign up for it. And I approach the monthly newsletter from a very decolonized perspective. It's a case of, hey,
Mhm.
this is what I've been up to, and here are some things that I'm doing in the future, but it's not like a huge sales pitch in any way.
Mhm. That's
Yeah.
great. Thank you. Yeah, I didn't know about the newsletter. I'll be signing up for that right after we finish up today. And we will have all that information in the show notes. So, for all of the hardworking therapists listening out there today, I want you to please remember that our work is hard, but it doesn't have to be lonely.